Hey everyone, this is Angry Bill. I'm here for Prehospital Wisdom. I wanted to start like a two-part series, at least a two-part series, maybe a three-part series on bradycardia and pacing and a whole bunch of stuff like that. But for right now, let's talk about a bradycardia patient, because I think there's some stuff that paramedics could bear to think about or consider changing about their bradycardia practice. So picture this scenario. You're dispatched to a delta unconscious patient. Further information is that a 62-year-old male was reported as unconscious and not breathing. Patient's now conscious. You have a BLS fire engine responding as well. No other resources are necessarily available closely for you. Supervisors out of service or whatever stuff your agency usually provides for you in cases like this. The location that you arrive to is a workshop or barn type thing next to a large house. You find the patient, who is indeed a 62-year-old man, inside on the floor. The general appearance is that of a fat 62-year-old, estimated to be about 250 pounds. He's pale, diaphoretic, tachypnic, and appearing generally ill and frightened. So let's work through some sample stuff, because I know a lot of people like that. Symptoms: chest pain. He's got crushing 10 out of 10 chest pain with radiation to the left arm. It's been lasting about 15 minutes. He also had a syncopal event. He was lowered to the ground without injury, being likely, and he faints again whenever he tries to sit up. Allergies: no known drug allergies. Medications: none. Past medical history: none, but he avoids doctors since he got out of the Marine Corps 40 years ago. Last meal: who cares? This mnemonic's sometimes pretty stupid. Events. The patient's a caretaker for a horse property and was feeding and watering horses. It's fairly low exertion for him when chest pain began. He walked to the barn where we are now, called for his coworker, and he woke up on the ground. The coworker states the patient called for help and was wobbling. He fell, caught him, lowered him to the ground. Hopefully that's kind of enough of a picture for you to deal with. Remember, this patient's looking profoundly ill, pale, diaphoretic, tachypnic, anxious appearing. And whenever you sit him up to try and talk to him, he faints again. So supine is the only way that he maintains level of consciousness. His initial vitals are a blood pressure of 80/40. His pulse is 40 and weak. He's got a respiratory rate of 24 and is set at 95% on room air. If you check it, his end tidal CO2 is at 28 millimeters of mercury and his blood sugar is 110. Yeah. Just by the way, hypoglycemia doesn't cause hypotension, so that would be fairly low on my priorities to check. His initial 12-lead EKG is here. So let's look at this and talk through it. First of all, I'm going to pause here for a second, though, while I let you look at it. I know. I do the same thing when Dr. Matu's videos come out on Mondays. He says to pause and take a look, and I just let the video run. I'm sure you guys are doing the same thing. In any case, let's talk through this. So this is a third-degree AV block. You can see the P waves and the peer intervals are changing. P to P intervals are regular. The R to R intervals are regular. One has nothing to do with the other. It has a narrow QRS complex, so I would describe this as a proximal third-degree AV block or a third-degree AV block with a junctional escape rhythm. One of the more standout findings on this is the ST elevation 2, 3, and AVF associated with hyperacute T waves. By hyperacute T waves, I mean T waves should never be bigger than the QRS complex that they're associated with. And in 2, 3, and AVF, you can completely hide the QRS complex under the T waves. There's also a little bit of ST depression, V1, V2, maybe V3, signifying the potential for posterior wall involvement. I'm not seeing any kind of obvious right ventricular involvement on this normal 12 lead. We would have to run a V4 right, and for the sake of this scenario, we'll say that V4 right was clear for us. Let's finish up the exam. He's anxious and atraumatic. His breath sounds are clear, but the patient appears dyspneic with tachypnea. His abdomen's soft. He has decision-making capacity when he's supine, and the patient faints when he is sat upright. So he's even going to be kind of a hassle to move off the ground. To be able to kind of pick him up and even get him to be flat on the bed again, you're going to end up sitting someone up just a little bit. So that'll be fun to look forward to. So in any case, what's our decision-making going on here, right? What are our priorities? Well, first of all, I think a STEMI alert is warranted. I don't know what your specific criteria is for a STEMI alert, but this patient has chest pain, a narrow QRS complex, greater than 2 millimeters of ST elevation and 2 or more anatomically contiguous leads. This qualifies as a STEMI, and the STEMI is even probably causing a third-degree AV block. So STEMI alert and rapid transport is certainly warranted. We are looking for a fairly short scene time, right? There's not a lot of screwing around here that I can be doing, but this patient does need stabilized. He's got a blood pressure 80/40, which is no joke. That works out to be a mean arterial pressure of somewhere around like 52 or 53 off the top of my head. That's probably why he can't maintain consciousness, and so we probably need to fix that. With there being a STEMI, I think you should consider a PCI facility if you're the kind of agency that has to make such decisions as well. So for treatment in general, I think this patient needs to be on the bradycardia algorithm. Whether you're using your algorithm from your protocols or from ACLS, this person is certainly a symptomatic bradycardia patient. This patient's having a STEMI. He probably has a right coronary artery occlusion. The inferior and probably posterior part of his heart's not working especially well. Do I really want to whip this heart with either atropine or pacing or epi? The answer to that is yes. There needs to be a minimal blood pressure. There needs to be a minimal level of cardiac effort in order to supply the heart. The coronary perfusion pressure, although is fairly low, it's not 80/40 with a map of 53 low. I don't need the patient to be at 120/80 or 110/70 or something like that. But I do need a little bit more blood pressure than 80/40. Now, we do need to talk about the bradycardia algorithm a little bit because I find a fairly common mistake. I'm not necessarily thinking of it as a mistake necessarily, but a fairly common finding is that paramedics end up confusing the bradycardia and tachycardia algorithms. So let me show you the ACLS tachycardia algorithm first. One of the main decision points is where you come down here and essentially we're looking, is this patient significantly ill? Is this patient in cardiopulmonary compromise? Shown by altered mentation, hypotension, stuff like that. So in this case, on the tachycardia algorithm, if you say no, you end the tachycardia with medication, and if you say yes, you end the tachycardia with electricity, or medicine by Edison, as the saying goes. The branch in tachycardia is not sick is medicine, sick is electricity. In bradycardia, in contrast, it's completely different. If this patient's not in a cardiopulmonary compromised state, we get to monitor him and watch him closely. If a patient is compromised, if this patient is sick, and really the simplest way to think about this is sick versus not sick, right? In this case, this patient is sick, so this patient needs treated. In tachycardias get treated. The decision is based on medication or electricity. In bradycardia, however, they're not all treated. Some of them are monitored. But if they are on the treatment line, we just work through the treatment line. In bradycardia, what I'm saying is not that the sicker the patient is, the more likely I am to jump to electricity. So the sicker the patient doesn't mean necessarily jump to pacing sooner. And in this case, with the narrow QRS, even with a third-degree AV block, I think there's an opportunity for atropine to work here. As I said, I'm not looking for atropine to raise his blood pressure to 120/80 or something like that, but I do need a little bit more cardiac output, especially in the diastolic phase, to feed some coronary vessels and stuff like that. So yes, I am real sorry I got to whip this sick horse. Just a little bit. Like, this horse doesn't have to gallop, but this horse does have to move a little bit more than it is moving. Most protocols for atropine call for 1 milligram every 3 to 5 minutes via IV or IO. Most of them end at 0.04 milligrams per kilogram maximum. In this case, that'd be about 4.5 milligrams for this 250-pound patient. So it's quite a bit of atropine that I can give them. I think honestly, I'd prefer 0.5 milligram if I have that opportunity. Honestly, I just want his pressure up a little bit. I got to kiss his pressure. Just bump it up, eke it up just a little bit. I don't need a big change in this. This is a recent change to most protocols. I remember most atropine protocols for most of my career being 0.5 to 1, and 0.5 never caused me problems. And I know that there's a theoretical process whereby it causes rebound or intractable bradycardia. I've never seen it or heard from it. And granted, this is my own anecdotal thing. I understand my anecdote does not data make. I've not had a problem with 0.5 milligram. And so honestly, I would prefer that. If you're more comfortable with 1 milligram, then that's 1 milligram. I'm okay with that. The times where I would jump straight to pacing is if I didn't have easy IV access. If I couldn't get an IV in this patient, I might go ahead and initiate pacemaking. Now, even that's going to be a suboptimal idea though, because transcutaneous pacing hurts. And so even when someone's unconscious, and I've had people with like a GCS of 3 and bradycardia, that pacemaker awakes them up. Pacemaking hurts. And so having that IV access for analgesia or for sedation is going to be kind of a priority as well. But also raising this pressure is a priority as well. This is one of those cases without a whole lot of easy answers. So I think the important lesson here is to try the atropine before the pacemaking. I think there's a chance that the atropine might not work, and that's okay. If it doesn't, switch to pacing. If I don't have IV access, that's okay, switch to pacing. A, the important parts are treat this, and B, I think it's right to start with atropine in this case, whether it's a milligram or not. Let's talk about how we pace this next. That'll be the next long form video, probably next week. Until then, let me know what you think of the atropine. Do you have a tendency to jump right to pacing or not? I do want to know, and I want to hear your reasonings why for it. I'm interested, please. Do all the YouTube stuff to like, subscribe, share. You don't need that explained to you anymore, do you? Until next time, I'm Angry Bill. This is Pre-Hospital Wisdom. Stay safe.